One of the biggest challenges that people face in recovering from psychophysiological or stress-related disorders is believing that the mind could be powerful enough to cause the illness. And this is because these disorders are so disruptive to the body. One of the ways that I try to help my patients understand this is by talking to them about placebo studies, because in the effects of the placebos, we see just how powerfully the mind can influence our organ systems. Let me tell you a little bit about what's known about placebos. Placebos, you know, are inactive substances, usually inactive, things like sugar or starch pills, that are given to people with some suggestion that they might help. Well, it turns out that among placebo pills, bigger pills are more effective than smaller pills, and 2 pills tend to be more effective than 1 pill. The dose-response curve of most placebos is remarkably similar to aspirin, ibuprofen, or acetaminophen. It reaches maximum efficacy in 20 to 30 minutes, and then it tends to trail off in its effectiveness after 4 to 6 hours. Now, active placebos are much more effective than passive placebos. An active placebo isn't just sugar or starch, it's some medicine that in some way causes some response in the body which is uncomfortable. So it's like giving somebody niacin that will make them flush, or giving them something that will give them a dry mouth, something so that the person can feel a change in the body, even if that change in the body has nothing to do with the purported effect of the placebo. To get really effective, though, it helps to move beyond pills. Injections tend to be much more effective than pills, and active injections, in other words, injections of substances that change how we feel in the body, are more effective than injections of saline. And as we'll soon see, the really powerful placebos are surgical. Let me give you some examples of the remarkable power of placebos. One of them, that dates from the 70s, involved treatment for temporomandibular joint disorder, which is pain that occurs in the joints of the jaw muscles and the jaw joint. It was thought in the 1960s and the 1970s that the epidemic of temporomandibular joint problems that was happening at the time were probably due to the deterioration of the joints. And oral surgeons were busy putting replacement kind of discs into the joint. They used Teflon, for example, for some of them. But the problem was that the Teflon started to deteriorate and they had big problems. So one enterprising group of dentists who thought, you know, I don't think this is about the structure of the jaw. I think this is about the patient's attitude toward the TMJ symptoms. They decided to try an intervention called sham tooth grinding. And what they did was they created a dental instrument that was, about 1 inch in diameter and maybe 6 or 8 inches long that vibrated a lot. And what they did was they told patients that they were going to realign their bite. And they would put this instrument into the patient's mouth and shake, rattle, and roll. They basically vibrated for some 40 or 45 minutes, after which they told the patient, we think we've done it. We've reconstituted or restructured the shape of your teeth so that you should have a better bite now, and this should resolve the difficulty. 64% of the patients who had sham tooth grinding had total or significant relief a year after simply one application of the procedure. Some studies are even more startling than that. I want you to reflect, if you were alive during the second half of the 20th century, as many of you probably were, roughly the period from 1950 to 2000, which group do you think of as having been more powerful in our societies? Doctors or lawyers? Take a moment to think about that. When I ask audiences, usually most people vote for the lawyers. But I think that's actually a recency effect. I think they're remembering around the year 2000. They're not really remembering what things were like in 1950. There's a common surgery that was done for angina pain. Angina pain, as you probably know, is pain that comes from partial or greater occlusion of blood vessels in and around the heart. And it's a kind of chest pain that comes from this. And it was found that they could do something called mammary artery ligation to resolve this. And what they would do is the following surgery. First, they would open up the chest. They made an incision all the way from the collarbone down most of the way to the navel. Then they would saw through the breastbone, they would retract the rib cage, and they would tie off this artery, the mammary artery, and then sew people back up again. And the logic behind this was that by tying off the mammary artery, you'd induce the heart to grow collateral vessels. It was kind of like creating nature's own bypass, if you will. And it used to work pretty well. They got 80 to 90% success rate of people recovering from angina pain with this surgery. The only fly in the ointment was that every once in a while, somebody would subsequently die and would have an autopsy. Not usually die from the surgery, but die from other causes. And upon autopsy, they never found the collateral vessels. So that raised the question, what's up? What could be causing the relief from the pain? One enterprising group of doctors thought, let's test this more scientifically. And they took the next series of patients that came into their hospital who were appropriate candidates for mammary artery ligation, and they did most of the surgery as usual. They did the incision from the collarbone down, they sawed through the breastbone, they retracted the rib cage, but they didn't actually touch the heart. They just sewed people back up again and told them that they had had successful mammary artery ligation. They then followed these patients and saw what happened once they healed, and what did they discover? 80 to 90% success rates. Same success rates that they had with the real mammary artery ligation. Now you as a modern person may be thinking there's an ethical problem with this. And indeed, perhaps there was an ethical problem. It's a little hard to find this journal article. It just so happens that the journal article reporting on the surgery was published by a little publishing house that is literally just down the road from where I live in Massachusetts. The name of the journal, you've probably never heard of it, it's called the New England Journal of Medicine. And it was published there in 1959 without a single mention of ethical issues. The next year, it caused quite a stir. Another team of doctors did the exact same surgery on a new group of patients, also not telling them about it. That was published in the American Journal of Cardiology in 1960. And then the lawyers got involved. They started saying, you can't do that. These are human beings. You have to give informed consent. Which, while I'm very sympathetic to that argument, entered us into the dark ages. Because then, how are we to know going forward when a surgical intervention seemed to be helpful to people and eliminate pain or reduce pain? How could we know whether it was a placebo effect or the effect of the surgery? Frankly, we couldn't. Until the year 2000, when we started coming out of the dark ages, because of a team of enterprising surgeons and researchers at the University of Texas. Because they actually came up with a plan by which they could do placebo-controlled surgery and get it past an institutional review board because it was an ethical plan. And here's what they did. They took subjects and they told them in advance that they were going to be randomly distributed to either arthroscopic debridement, which meant making little incisions around the knee to do arthroscopic surgery and smoothing out the structures under the kneecap, arthroscopic lavage, which meant washing out the structures under the kneecap, or the incisions only. That was the placebo group. And they followed these folks for 2 years. The study was very well done because what happened was the surgeons did the surgery, but then they never saw the patients again. The researchers followed them in the postoperative period and then on over the next 2 years, and the researchers were completely blind to the condition. They had no idea who had had the surgery and who had not had real surgery but only had placebo interventions. Now, because of my interest in placebo research and because I use it clinically to help patients understand that the mind is so powerful in its effects on the body, I was following this study very closely. And at the end of the study, it got a lot of media attention, and I was listening on National Public Radio while they interviewed one of the subjects who had been in the study. And this subject said that he was very glad to have participated because starting about a week or so after the surgery, once the incisions healed, he had felt much better and he'd actually been free from knee pain for the last 2 years. And what he said was, I think the surgeons were top-notch because clearly they cured me, but the researchers, they were very sweet, very nice, supportive people, but they weren't as competent as the surgeons. The reporter said, what makes you say that? And he said, well, the other day, when they finished the study, the researchers got all confused. They thought I was in the placebo group. Everybody improved. Real surgery had no advantage over the placebo at any point during 2 years following surgery. This is very powerful stuff. Let's look at acupuncture. These effects aren't simply limited to surgery. In 2005, there were 2 large, high-quality trials in patients with headache. They found little difference between the effects of acupuncture and placebo acupuncture, but a very big difference between placebo acupuncture and no acupuncture at all. It turned out that placebo acupuncture was pretty much as good as real acupuncture. Then in 2002, there were 131 consecutive lower back pain patients at a university in Germany were randomly assigned to 3 groups. And each group received active physiotherapy across the whole study. The control group got no further treatment. There was an acupuncture group that got 20 sessions of traditional acupuncture, and then there was a sham acupuncture group that got 20 sessions of sham acupuncture. Now, sham acupuncture is an interesting procedure. They stuck in needles, but they stuck them in superficially, and they stuck them between 10 and 20 millimeters away from the true acupoints outside of the meridians. And the needles weren't stimulated, as they often are in real acupuncture. They found significant improvement in traditional acupuncture for chronic low back pain compared to the routine care, the physical therapy, but no difference from sham acupuncture. Sham acupuncture also worked just as well. Josephine Briggs is the doctor who's the director of the National Institute for Health, the Center for Complementary and Alternative Medicine here in the United States, and she's come to the conclusion that acupuncture is a particularly effective placebo intervention. It's so well designed with a whole ritual. It involves breaking of the skin, which we know works so much better than simply taking pills. It requires time, and the person has a full body experience when they go in for acupuncture. Perhaps even more remarkably, we now know that placebo interventions will work even when people know that they're getting a placebo intervention. There's a Center for Placebo Studies in one of the Harvard teaching hospitals, and they took 80 patients who were randomized to either open-label placebo pills. In other words, they were told this. They were told placebo pills are made of an inert substance, like sugar pills, and they've been shown in clinical studies to provide significant improvement in irritable bowel syndromes through mind-body self-healing processes. And the subjects had irritable bowel syndrome. So they thought, okay, this can work. But they were told that these are sugar pills. They were told the truth, which is that sugar pills do help with this disorder. So they either got the placebo pills or they were in no treatment control group that got the same quality and type of interaction with the providers, but no placebos. The people with the open label placebos had significantly higher global improvement scores on their irritable bowel syndrome symptoms at both 11-day midpoint of the study and at the 21-day endpoint. What was fascinating to me, I was following this on the radio also, was that the patients after the study who had gotten the placebo pills said, "This is great, thank you, I'm glad I participated. Where can I continue to get the placebo pills?" And the researchers said, "Well, they're just inert. You could use Tic Tacs." And the subject said, no, I want those placebo pills. Those are what worked for me." And they were actually upset when the researchers couldn't provide them because there were various ethical and legal strictures that made it so that they wouldn't do it. Okay, so these stories are presented to you, and I present them to my patients so that we can get an idea that, wow, the body and the mind are closely interacting with one another, and the mind is extremely powerful in the effects that it can have on our subjective experience of the body. So how do we use these principles to treat other disorders? Let's look at other muscle tension disorders, which are remarkably similar to chronic back pain in their dynamics. And here I'm talking about headaches, temporomandibular joint disorder, a lot of neck, knee, foot, wrist, and shoulder pain. Now, we don't have quite the data we have about these disorders that we have with chronic back pain. With chronic back pain, we know that the correlation between what's found in the imaging of the spine and what people experience in terms of subjective distress is very, very low. That the condition of the spine only rarely actually influences whether or not people will be in pain. It's not never. There are people for whom, yes, it's the spine that's causing the problem, and yes, repair of the spine is what's called for. But in the vast majority of cases, this isn't the case. With the case of neck, knee, wrist, shoulder pain, we don't quite have the data, largely because we haven't done large-scale studies in which we take people without knee pain, without shoulder pain, without wrist pain, and take a look at what the body parts look like for them. The preliminary data is interesting. For example, there was a study of knee pain that showed that a torn meniscus is very common in men over the age of 55. The majority of pain-free men have a torn meniscus. And there are studies that showed that Major League Baseball players who are pitching balls at nearly 100 miles an hour typically have torn rotator cuffs. And as we know, a torn meniscus or a torn rotator cuff is sometimes pointed to as the cause of the pain. So the science isn't in here yet. But the basic principle of treatment is the same. Rule out structural causes if you can and follow the same 4-step program. Let's move on to some other areas. Let's move on, for example, to sexual dysfunctions. It's basically fear of the dysfunction that brings on the dysfunction. Let's take erectile dysfunction as an example. You know, before we had Viagra and Cialis, we had the interventions of Masters and Johnson. They were the kind of the original sex therapists. And they had some pretty effective non-pharmacological treatments. And they all targeted awareness of present experience with acceptance. They taught what they called sensate focus. And here's what the instructions were like. They would send a couple home and they would say, here's the deal. I want you to touch one another in a sensual and sexual way. Only there are rules to this. You're not allowed to pet to orgasm and you're not allowed to have intercourse. What you need to do instead is to simply bring your attention to the sensations of touching your partner if you're the one doing the touching, or being touched by your partner if you're the one being touched. And every time your mind wanders and goes off to other things, just gently bring your attention back to the sensations of touching or being touched and let go of any goal orientation and simply accept whatever happens. At this point in the course, this should sound familiar to you. They were teaching mindfulness practice where the focus was sensual touch. And they found, for example, with erectile dysfunction, that about 75% of the time, just training couples to do this would resolve the disorder. They also addressed other issues, such as people's attitudes towards sexuality and the dynamics of the couple's relationship, whether people felt close or not. Nowadays, I'm sorry to say, these kinds of interventions are a little bit academic. We have Viagra and Cialis, where people who don't really like each other and can't communicate can successfully have intercourse on a regular basis. Let's look at insomnia. The conventional treatment for insomnia is stimulus control, sleep hygiene, and relaxation. And stimulus control means we want to teach people to associate the bed with sleep. And the standard instruction is, I want you to reserve the bed for sleep and sex. Now, if we're really being logical about this, and we want to develop a paired association between the bed and sleep, we should really reserve it for just sleep. Not just not reading and not watching TV, but not having sex either. We should be saying you should have sex in another room, but sleep in the bed. I'm afraid that researchers have been a little bit too prudish to say have sex in the living room, sleep in the bed, so we include both. The second thing we ask for is sleep hygiene. That means get up the same time each day, even if you haven't had a full night's sleep, and try to go to bed the same time each day, even if you're not tired. And thirdly, they do relaxation training. An alternative is to do mindfulness treatment. And the way mindfulness treatment works is to simply use the time in bed as an opportunity to be aware of present experience with acceptance. This is frankly what I do every night when I go to sleep. I lie down, I close my eyes, and I begin following the breath as we've done in the breath awareness training. If the mind wanders to other things, I gently bring the attention back to the breath. Now, it turns out that mindfulness practice actually reduces our need for sleep. People who go on meditation retreats, who are doing mindfulness practice all day long, find that they need a lot less sleep. And there's two theories to this. One is that what's happening is that some of the processing of what happens, the restorative functions of sleep, is happening in mindfulness therapy or in mindfulness practice. Well, you could think of this, that what's happening in sleep is all sorts of unintegrated material is being reintegrated, right? We're reconnecting with thoughts and feelings and memories that might have been difficult to be with. So if some of that's happening while we're doing the mindfulness practice, we don't need as many hours of sleep to do it. The other hypothesis is that because we work through these things, we tend to sleep more deeply during the hours that we are sleeping so that it's more efficient. Either way, what happens is if we trust that mindfulness practice will help to be restorative for us, then we can give up the goal orientation. And we all know that it is much easier typically to fall asleep on a Friday night if you don't work over the weekend than it is on a Sunday night if you work during the week. Because on Sunday night you're thinking, gosh, I got to get to bed so I'll be well rested, otherwise tomorrow's going to be a disaster at work. Whereas on Friday night, it doesn't really matter. So when we remove the goal orientation, that helps a great deal. So the way I think of it is one of two things is going to happen. I'm either going to have the opportunity for 8 uninterrupted hours of mindfulness practice, pretty good in a busy life, don't get that opportunity that often, or I'm going to fail and I'm going to fall asleep, and that would be fine as well. Let's look at gastrointestinal distress. Now, this system is remarkably sensitive to our emotional lives. What the stress physiologists tell us is there's no need to digest your own lunch when you're about to become somebody else's lunch. So our GI system will often shut down when we're under stress, or it will suddenly become overactive, kind of dump its load, if you will, so we can run away. And people experience all manner of gastrointestinal distress. They experience upper GI symptoms in which the stomach is producing too much stomach acid and churning too much, and they experience lower GI symptoms very often that have to do with having alternating diarrhea and constipation, as we see in irritable bowel syndrome or other kinds of disruptions. Now, ulcers were once thought to be caused by stress. And then we discovered the role of H. pylori. Turns out that you could treat an ulcer by giving an antibiotic that kills H. pylori bacteria, and often it would heal. But then we discovered that H. pylori infections are actually endemic to large percentages of the population. In fact, there are some countries, I know Colombia is one of them, in which the majority of people have H. pylori infections. So then that brings up the question, so what's determining whether somebody with H. pylori infection gets an ulcer or not? Well, we're back to the stress hypothesis. It turns out that stress is a critical factor in whether the stomach lining becomes broken down in a way that makes it vulnerable to the infection. I mentioned irritable bowel syndrome. This is very, very common as a disorder, and this is where you have this often alternating constipation and diarrhea. And here, the distress about the symptom is often the stressor that keeps it going, not unlike what we saw in chronic back pain. So a person's afraid that they're going to be caught off guard and suddenly need the bathroom, and they won't be in a place where it's convenient. Or they're afraid that they're going to get backed up and they're going to feel terrible cramping and things, and that's going to get in the way of participating in life. It's only when people can relax about IBS and actually use mindfulness practices to simply ride the waves of different sensations, like, okay, this is what needing to go feels like, okay, this is what being stopped up feels like, then they do considerably better. This is true for the upper GI symptoms as well. Very often people start to micromanage their diets. They start to try to figure out which foods are making me feel better or worse, and then eliminating foods from their diet. Now, of course, there are genuine food allergies, and these need to be treated medically. However, for a lot of people, what happens is, as they're trying to figure this out, as they're becoming a junior scientist, we can't differentiate from eating a tomato being problematic because the tomato is interacting with our stomach in a bad way, or whether the thought of eating a tomato is causing us anxiety, and that anxiety is upsetting our stomach. Because as soon as we have the experience of a tomato making our stomach worse, we're locked in a pattern where all future tomatoes will make our stomach worse through the anxiety mechanism. So mindfulness practices can help us with this. Mindfulness practices can help us to simply ride out these changing waves of sensations. I got into treating psychophysiological disorders because I've had a lot of them, and I remember when I was applying to grad school, I had a lot of upper GI distress. I remember asking my girlfriend at the time, what does a normal stomach feel like? And she said, you know, it's hard to describe, but I'll tell you this, you just don't think about it that much. Another interesting disorder that works similarly is something called hyperacusis. I've actually treated a lot of this. It's a somewhat unusual disorder where people become afraid of loud sounds, and that loud sounds don't just feel uncomfortable, but they become terribly painful to people. And what people do naturally is they try to avoid loud sounds. And they get themselves into a pattern which is like what would happen if they had photophobia, which is a disorder in which normal levels of light are too bright. We all experience this a little bit if you ever go to the eye doctor and you have your pupils dilated so that it lets in all the light. If you were to respond to that all the time by wearing dark glasses, what do you imagine it would be like to take off the dark glasses on a bright afternoon? It would be unbearable. Well, the same thing happens with hyperacusis. What happens is people become so phobic of loud noise, and they work so hard to avoid loud noise that then any noise becomes too intense. You can use mindfulness practice to try to resolve hyperacusis, and it actually works quite well. To simply listen to the noise and notice, this is separating the two arrows that we discussed before, noticing how there's the actual experience of the sound, the sensations, and then there's our reaction to the sensations. And as we notice that these can be separated, it becomes much easier to work with the symptoms. Now, another disorder you may have heard of is fibromyalgia. And this is a bit controversial. This was identified as a disorder in 1990, in which they identified these trigger points, these spots in the body in which people with this disorder felt particular sensitivity to pain. And it was established by the American College of Rheumatology as an official disorder back then. What we've later learned, though, is that people with fibromyalgia are actually sensitive to pain everywhere. You could take any part of their body, even like the thumb, put it in a little vise, not something dangerous, just something used for research, squeeze the thumb, and they will report a level of pain equivalent to what a person without the disorder feels at half the amount of pressure. So you only give a pound of pressure, and the person experiences pain that somebody else would experience as 2 pounds of pressure. Dr. Frederick Wolf, who was the one who first identified the disorder, has said, I'm afraid we're creating an illness rather than curing one, because this has become something of an epidemic. And just to show you how this gets in the complicated political and social milieu we work in Scotland, in the United Kingdom, those psychologists and physicians who are treating fibromyalgia as a stress-related disorder have needed Scotland Yard protection because people suffering from the disease are saying you're just not trying hard enough to find the underlying mechanism. That may be true, but it may also be one of the stress-related disorders. Now, illness anxiety is a component of all of these different disorders. And it's unavailable. It's unavoidable. One of the reasons why the Buddha supposedly left the palace and went out into the world to follow spiritual practices was because of illness anxiety. And illness anxiety is actually remarkably easy to generate. Let's try some right now. Take a moment, and if you can, close your eyes. And I want you to sense whatever is happening inside your head right now. And see if you can sense a little bit of discomfort, maybe a kind of pressure that's there. Just try it. See, can you feel any pressure in your head? And see if you can sense a kind of pressure that, if it were to get more intense, might start developing into a headache. Uh-oh, it may be happening. We find that people who live with folks with brain tumors have a lot more headaches than people who don't live with folks with brain tumors. And folks who have had chronic headaches before rivet on any sensation of pressure, and it becomes a problem. It expands into a headache. Or consider this. Imagine that you just learned that there's something wrong with your laundry, and there's been a lice outbreak, and there's some in your clothes. And just feel what's happening in your body right now, and notice whether you sense any itching anywhere. Maybe around the scalp, maybe somewhere else. Uh-oh, it could just be lice. Oh, I got another notice. It said it actually doesn't affect your laundry, just other people's laundry. It's important to undo hypnotic suggestions. So you probably notice, if you try those experiments, that all it takes is bringing anxious attention to a part of our body, and we can start to feel sensations in that part of our body and start to worry about them. And these things can get amplified very easily. Now, we have two basic reactions when we experience something untoward in the body. When we're younger, and it helps if you come from certain ethnicities, you may think it's probably nothing. You may think, oh, this is just a coming or going sensation. I don't really have to worry about it. But if you're older, you may start to think it's probably something serious. And this happens too if you grow up in an ethnicity or a family that's very focused on medical disorders. One of my favorite cartoons about this has an anxious woman, and she's reading the big book of horrible rare diseases. Near her feet is the Merck Manual, A Child's Garden of Maladies, Lockjaw Monthly, and all these other reading materials, which now that we have the internet, can be any of us, because we can all search online for a symptom and get some pretty scary possibilities about it. What happens is illness anxiety itself can become the problem, and it can be very tricky to figure out which error to make. You wouldn't want to ignore a grapefruit-sized growth coming out of your neck and think it's probably a zit, but nor do we want to rivet on and pay attention to every one of these different sensations when they arise, because doing that can make any of these sensations turn into one of these disorders. Now, the biggest challenge, or I shouldn't say the biggest challenge, but an important challenge to keep in mind when we're treating for ourselves or others these stress-related disorders is to realize that even if we're a good mindfulness student and even if we take a good attitude toward these disorders, we can still run into trouble. Now, no matter how good we are as a mindfulness student, we're all headed for the same place, and the bodies are going to fall apart eventually. And some of these disorders are resolvable and some are not, and we don't want to fall into the trap of blaming ourselves for a disorder that we can't resolve. In our next lecture, we're going to look at another big challenge for most of us, and that's troubling habits, including the addictions. And these will look at everything from everyday behavior to those kinds of habits that can really get us into trouble. Thanks for listening.